Okay, welcome to the July Wye Valley Trust Board. This is the first time we've live streamed onto YouTube, and we hope you find it a useful forum. If you do want to ask any questions, you can do so within YouTube, and we will respond to those questions as quickly as we can. I'm delighted to welcome our new HR and OD Director, Jeff, who's joining us today. And we don't, I think, have any apologies apart from Bex Grattan, who is unable to join us. Are there any new declarations of interest? Please come off mute if there are. Okay, so that's duly noted. We, just for members of the public information, had a good board workshop this morning. We met colleagues from the Hereford and Worcester Partnership Trust, who briefed us on the work they do in the community and with mental health. We had a fantastic presentation from our ICU team on the response and the frontline activity that's gone on through COVID-19. And then we had a session led by Jane Ives, our Managing Director, on the anchor institution role and the future developments of the system within Herefordshire. So a productive morning for the board, but now we're on to the public board. So the matters are, the minutes of the meeting held on the 4th of June. Was everyone happy with the accuracy of those minutes? Please come off mute if you weren't. Okay, thank you. So I will duly sign the minutes. Therefore, we come to matters arising, which are on page 10 of 124. The first was a board workshop to be held early in 2020 to discuss the NHS as an anchor institution. As I said, we did that this morning. Thank you, Jane. We then had a question from Andrew, who would contact the John Barnes, our Chief Operating Officer, around certain information on increasing numbers on the performance reports, and that was done. Thank you, Andrew and John. We then had a question on the capital report, and that's on the July board agenda for later on. Thank you, Alan. In terms of actions in progress, John Barnes will reflect the information on theatre productivity. That's now going to be handled in August 2020 and has been delayed due to the COVID-19 challenges that we know and are well informed of. We then had the Realising the Group approach to leadership, and a board workshop is going to be held on that. But Jeff, you're going to lead that when you're, if you like, you've got your feet fully under the table. So looking forward to that. On the quality side, we're going to have a board workshop on end-of-life care, and we're hoping to do that in August, Jane. So I leave that with you and Lucy and David. And then a board workshop to be held on the IMT strategy. It's going to be busy. That's also going to be in August. And Howard will be leading that. We then had a detailed response to the next board assurance framework report regarding risk 13 on the continued high turnover of nurses. We will come back to that, and that's due in August as well, Erica, so thank you. And we then had on the finance report, Howard to review how typical the substantive medical staff additional payments are and compare these to other trusts. And as I understand it, that work is underway, Howard, as part of the foundation group work. So we look forward to seeing the output from that. And then finally, I would ensure the work carried out at Swift regarding Babylon is shared with the Chief Operating Officer. Glenn, just brief us quickly, if you can, where we are at Swift on that.
Yeah, so we've had conversations across the group now with I think John was involved in that with Andy Laverick as our digital lead, and we're looking at the Babylon solution, but there's also another one in the market which ties in a little bit to the comments I'm making in my Chief Exec report in a moment in terms of digital opportunities.
Super. Thank you very much, Glenn. Are there any matters arising that I have missed? Okay, so on that basis, we'll move on and we move into the review and assurance section of our report. And Glenn, your Chief Executive's report first, please.
Thank you, Chairman. So I think last time I mentioned or suggested I might come back to you on an update on the test and trace programme, which is the first item. I think it's probably, well, it is a coming together of the NHS and Public Health England. So the testing is being carried out by the NHS plus some independent sector labs, or lighthouse labs, as I've referred to in last month's report, but then Public Health England linking in with local authorities are dealing with the tracing programme. And what this report identifies is just the way that's going to work. I think the most notable thing for us is the management of any NHS workers who are identified through tracing is in liaison with us. So, for example, if a member of staff is wearing full PPE, then the risk assessment would not lead to us needing to isolate that individual as a consequence of a contact. So it's a sensible approach. And probably before I move off testing, I should just give an update that we talked last time about offering antibody testing to all NHS staff, and the aim is that by the end of next week, all staff will have been offered access to testing. And thanks to Erica and colleagues, we've managed to achieve over 90% of our staff at Wye Valley actually having the test, which is a very high level, actually, certainly compared to the rest of the group. So well done. Then I move on to the A&E triage thing. So we just talked a little bit about that. So the Royal College of Emergency Medicine has been talking about a call before you walk approach. The intention here is that we don't go back to a situation where A&E departments are being used for what could otherwise be primary care or other services. And indeed, when you talk to A&E colleagues, many of the inappropriate use are people who didn't actually need to access the NHS at all. So we are looking, as we just said, at potential digital front door options for A&E across the group, and we'll come back to you on that. Then I'll give you the happy news that CQC will be restarting their inspections, which I won't dwell on. The financial regime then is the last item there. So much work is going on at the moment. Obviously, we've got this arrangement for the first 4 months of the year, which has been extended to the first 6 months of the year, which is in effect a block contract with top up for recognised additional COVID costs. There is talk now of moving to a situation where we fund systems rather than individual organisations, and that's something that I have to admit I'm a little bit concerned about. So I've got a conversation next week with the national team. NHS providers are also helping, particularly provider chief execs, to get the message over that the governance, the local accountability, the responsiveness that comes with organisations like ours is something that we should be trying to use as part of speeding up recovery and managing the risks. But pushing money into systems that are in some cases not mature enough to manage the governance, and certainly not accountable as systems, or accountable as the individual organisations that make them up. So there's some risks there. So I think the phase 3 letter is referred to, which we'll see in early July. Hopefully there's an opportunity to influence the way this is done. It's going to be a very complex thing to restart the NHS. And so I think using the strong accountability that we have in an organisation like ours is probably the best chance we have of doing that as well as we possibly can. That's all I wanted to flag.
Thank you very much, Glenn. So I'll invite questions from the non-execs first. Please just come off mute if you have any questions. Richard Humphreys, any questions or perspectives from you? Christabel, any from you?
Thank you, Chair. I was just interested in what the early picture is on the situation with A&E and whether we have already got inappropriate attendances. Is there any early lessons to be learned?
Yeah, I mean, John may come to the moment. Obviously, the demand is continuing to rise. But I mean, one of the features of our our increasing demand over the past few years has actually been ambulance conveyed activity. So that activity is highly likely to be inappropriate. I think the other thing about the inappropriate use is obviously these individuals are needing access to something. So it is about routing them to the best first point of contact. And the experience of using Babylon in UHB particularly has allowed the ability to take patients straight into things like same-day emergency care via appointments, rather than necessarily needing to queue or wait. And particularly at the moment, queuing is a risky business. So so I think that those kind of things are going to help us through COVID. But demand has increased, isn't it, John? I don't know if you wanted to make comment on that, or potentially later in the performance report.
Let's pick it up in the performance report if we can, John, at that point. Thank you, Chris. Richard, I think you had a problem hitting the mute button. Richard, any questions or perspectives from you?
Sorry about that, Russell. I hit the video button instead of the mute button. This technology. It was a question about testing and tracing, Glenn. And in view of what's happened in Leicester, and noting that we also have a significant outbreak down the road in Merthyr Tydfil, just seeking assurance really that we've got the local arrangements in place, including access to data, that we could respond to any outbreak in Herefordshire in a swift and timely way.
Yeah, and one of the things that's notable about the arrangements that are in place is the capacity for tracers that's been. So there's an arrangement where we've got local public health experts, plus topped up by additional staff during this crisis, and those additional staff are not being fully used at the moment. That's evident from the national data. So we have the capacity to do it. I think one of the concerns has been linked to the ability to get data on testing back out of the independent sector laboratories that are helping us during this, and there's some IT issues that have been affecting that. I'm being assured that's being picked up, but it's not as rapid as I would expect to be. Certainly the feedback from the NHS labs and the Public Health England labs that exist is very rapid feedback, but the Lighthouse labs do need to speed up a little bit.
Thank you, Glenn. Keeping the pace going. Nicola, any questions or perspectives from you?
No, my perspective was just building on what Chris said and about A&E and perhaps any challenges we might see after some form of returning to normal with all the pubs opening on Saturday. Might that give us some back to normal challenges at the weekend?
Okay, John, do you want to pick that up in your report?
Yeah, I mean, I was just going to comment. We've been asked to prepare for New Year's Eve-like levels of A&E activity, which is a very worrying scenario, and I hope it doesn't come to that. But being ready for what happens on Saturday is an important and immediate task.
Thank you. And Frank, any questions or perspectives from you? Just come off mute if there are. Andrew, any questions or perspectives from you?
Yeah, just we discussed earlier the financial regime, and my sense of what you said just now, Glenn, is that you're not averse to the principles that have been considered in terms of system-wide allocations and budgets for population groups. It's really a question of the organisational maturity, I think you're sort of highlighting, that you're concerned about. And my other comment really is just something you've put in your report, just with flagging, I think, that the cost of delivery, certainly on a unit cost basis, will be higher, won't it?
Yeah, it absolutely will, and I think it's quite hard to benchmark that at the moment to understand. Obviously, we will get more proficient in working under these conditions, so our productivity will improve, but we're certainly put through less activity per overhead than we did before. So that's something we need to keep a very close eye on, and we've actually started some benchmarking across the group on that so that we could look at how that's going. In terms of your point, yes, I'm not opposed to movement to capitation-based funding. I think that is the future model that we ought to be willing to operate in as a lead provider in our system. My issue is system accountability across an STP for us, across Hereford and Worcester, which there is no accountability in the system. It has to be the individual organisation. So giving capitation funding to us as a lead provider in Herefordshire would work. but giving it to a kind of nebulous system has risks.
Okay, thank you, Andrew. Can I just remind all colleagues that if you have a whiteboard behind you, that on YouTube Live, members of the public will be able to see what's on your whiteboard. And Grace, any questions or perspectives from you?
Yes, thank you, Chair. I really appreciate the discussion and about the ownership of accountability, which I think is absolutely vital. And my question was, how will the new financial regime impact us as a small rural trust? Are there any different discrepancies or differences there to larger organisations?
Okay, thank you. Glenn?
Good question. Members of the public will see on my wall behind me is a picture of a gentleman with his head in his hands. So in answer to that question, the financial regime is funding on a block basis based on levels of income that we had towards the end of last year. What we need in the longer term is a more sophisticated model which takes account of the cost of delivery according to the local circumstances. So we've been lobbying for the last couple of years on taking account of rurality in the way that the system is funded, and I could talk at length about that one, but I'm hopeful that they will make some adjustments to that. I mean, one of the things that we've been working on over the last few weeks has just been looking at the cost of delivering training to doctors, for example, where we incur additional costs compared to any other provider in the Midlands. It's really important that we offer that training. They get training in a place like Hereford, which is great access to kind of the general nature of medical training, but it's an additional cost. So we do need that to be recognised in the future model. There's no clarity on whether it has been recognised yet, Grace, but it's something that we will not give up on.
Okay, great. Thank you very much, Glenn. And if there are no other questions from executive colleagues, we'll move on to the integrated performance dashboard. So thank you, Glenn. So Jane, do you want to introduce this and we'll keep the pace going? Thank you.
Yes, just a few words of introduction, because in a way it's quite a similar story to last month, where reducing levels of COVID that we're seeing and we're looking after patients with, which is all good news. The reduced levels of activity and reduced levels of demand, although that is starting to come up, but nowhere near back to where we were before. So in the performance report is now a COVID KPI section, which has got some of that information in. So John will talk through that in his section and what that means to our restoration and recovery programme. But broadly, in terms of restoration, which was urgent services to come back, and those are all back in place. So the planning for recovery, which is the more routine, is now really well advanced and is starting to take place in some specialties, but not all specialties yet. But John will cover that under the KPI section, in the COVID KPI section in his section. I think an area I'd like to draw attention to is the National Inpatient Service. This is being published today, and so we'll come back to this at board next month or the month after. But I think it's something that I am concerned about, the team is concerned about. This is a set of measures that just haven't shifted really over the last few years. And certainly my expectation was, with the increasing in staff satisfaction, I was sort of expecting to see that rise in patient satisfaction as well. I mean, that generally happy staff means happy patients, but it hasn't come through. And so there's something, I think, about the way that we've tackled this in the past that hasn't worked. So Lucy's leading the work on this, and we're going to look at how we refresh this and how we really make a difference to patient experience, because what they're saying to us is that it's not as good in many areas as it is in other places in the country, and it isn't shifting, it isn't getting better. So so there's more for us to do, and so Lucy will be leading that work. I think what is positive though is around the surgical division. So even though they've been grappling with the restoration recovery programme, I think they are making some good progress in terms of safety culture, and the work that they're doing on that is pretty innovative actually. And I think they've used quite a lot of the COVID learning to then inform what they're doing for for the future and to improve their safety culture. So that's really encouraging. And then the last area I just point out is in terms of risk assessments for COVID, particularly for our Bane staff. So we're at 70% of those risk assessments have been done, which is not bad, but not good enough yet. So within the next 2 weeks, we'll get to 100% of those risk assessments, so that we've made sure that we've assessed all of our staff, not just Bane staff, but all of our staff who may be at risk, and made sure that we've got appropriate systems in place for them.
Thank you very much, Jane. Any questions or perspectives to Jane, or should we dive into the detail? Just come off if you do have a question or perspective. Okay, we'll go into the detail first then on quality. Lucy, thank you.
Thank you, Russell. Jane's probably covered a couple of points that I want to talk about, but I will talk about those in detail, if I may, when we get to them. I'll take the report largely as read. And the first thing I did want to draw attention to actually was the good work that theatres is doing. So obviously the CQC inspection highlighted that there was more work to be done there, particularly around culture and governance. And what's been highlighted in the last couple of months is really good clinical engagement, strong leadership at divisional level, and certainly that new management structure at directorate level starting to have an impact on that safety culture. And contained within the report was just some details of their first simulated human factors safety training session that they did around the theatre safety checklist, which we've heard about previously at board. And indeed, Quality Committee received an update from the surgical division last month, just around the strengthening of their governance arrangements. And they've certainly got a clear plan of how they're going to strengthen that. We just need to see that embedded into everyday practice. The second thing I just want to talk about is Quality Committee received the regular quarterly updates for pressure ulcers and falls at its meeting last week. It's good to know the continued progress we're making in relation to patients not developing pressure ulcers in our care. So that's really good news. But we've certainly got more work to do around those patients who are sustaining moisture-associated skin damage in our care. And our early analysis is showing that we've got work to do with care providers going into patients' homes, where patients are receiving care in their own homes, but multiple providers going in and not necessarily following the plans of care that we're putting in place for our patients. And then an interesting one, we had an interesting debate at Quality Committee about what's happened with falls recently. And I put in the paper a hypothesis around why might we be seeing a higher falls rate. And indeed, our early thoughts are that perhaps patients are, before they come into hospital, perhaps deconditioning at home because of lockdowns, so not as active as they would normally be. Deconditioning, we're probably getting sicker patients in our hospital than we normally would, and therefore we're seeing our falls rates increase. Or is it about the way that we're delivering our care? So is it that because of the infection, we're having to have more patients treated behind closed doors? We've got visiting restrictions, which means there's less observation of our patients to prevent them from falling. And we don't know the answers. As I say, I pose it as a hypothesis in the paper, and I'm sure the intelligence on that will develop as we move forward. James already alluded to the CQC publishing the National Inpatient Survey today. We discussed the findings of that at our Patient Experience Committee on Wednesday of this week, and I'll be doing a presentation at our Trust Management Board tomorrow. And as Jane says, disappointing really, and certainly more work to do there. And there are a number of perennial issues that we've got to tackle, and we've got to take a new approach to how we're going to tackle those. And certainly the early feedback from the Patient Experience Committee this week was perhaps we need to approach that in the same way we did valuing patients' time earlier in the year, and sort of get a frontline response to the solutions to addressing those things that our patients are telling us. Although it's not contained within the report, I do just want to touch briefly on some feedback we've had from patients recently or their relatives around not being able to visit our patients. And indeed, we never expected COVID to come, and we would never ordinarily want to have the visiting restrictions in place that we've got at the moment. Our visiting restrictions are in line with government guidance and are consistent across Herefordshire and Worcestershire, so that patients experiencing care in any setting. Oh, it says I'm muted by the host. Is that true, or is that
no?
just...
You're now. We can hear you, Lucy.
That's okay. So we had a Herefordshire and Worcestershire Director of Nursing discussion earlier this week, where we have agreed to review our visiting restrictions, and we aim to work up a plan to lift some of those restrictions towards the end of July, beginning of August. But we need to be clear that's going to be very different from how visiting used to be, because we'll have to keep that safe both for our patients, our staff, and anybody entering our hospital. And then two final things from me. There's a little bit of information in there just about the fantastic, how significantly our vacancy factor has reduced in the last few months. And ever since I joined the organisation 4 years ago, there are a number of our medical wards that have had a significant vacancy factor. And those wards are now, for the first time in 4 years, have no vacancies, so no nursing vacancies. And across the medicine division, which has always been one of the divisions that's the most problematic to recruit nurses to, they're down to just 15 full-time equivalent nursing vacancies across all of their wards, which is fantastic. And then a final thing from me, it should have been a deep dive on infection prevention and control this month, but the Infection Prevention and Control Board Assurance Framework is later on the agenda, and I'll talk to it then. Thank you.
Thank you, Lucy. Very comprehensive. If we can keep the pace going. Richard, any questions or perspectives from you? Just come off mute. Andrew?
Yeah, just really helpful to get an update on the pressure ulcers and the problems coming from the outside. I'm just, yeah, helpful to get that. And hopefully we'll continue to get some detail at board level.
Okay, thank you, Andrew. Frank? Sorry, Frank, any questions? No. Grace, anything from you? Just come off mute if there are. Okay, Chris, anything from you? Chris, just before I pass on, can I thank you for your ongoing work as Chair of Quality Assurance? It's absolutely essential, and I know the work you do with Lucy takes up a voluminous amount of time, so thank you. Nicola, anything from you? Okie dokie. And anything from exec colleagues? Okay, so moving on then to activity. John. Sorry.
Russell, I think Howard wanted to speak.
Apologies, Howard. You've got to come off mute faster. Howard?
Yeah, I thought I was pretty fast off the button there, but anyway, not to worry. No, the point I was just going to make, and it's something I will talk with Lucy offline actually, but that is that it's brilliant news about the vacancy rate. I'm just not sure that we're seeing the same rate of improvement in the agency usage comparatively. So I think that's something which we need to just take a bit more look at.
May well be a lag in that type of thing, Howard, but keep us briefed. It would be good to pick that up in the minutes and come back to it in the actions arising next month. Thank you. So moving on then, John, tell us about how busy we are.
I'll take the report mostly as read and just try and focus on the COVID elements, because in truth, nearly everything else we do has been affected by COVID for this reporting period. I'll start by saying that whilst the numbers of patients in our beds has reduced, particularly over the last few weeks, we still do have some operational clinical impact from COVID in terms of both dealing with patients that are here and also the COVID precautions. So it does, as has been alluded to already, really impact some of our productivity and efficiencies and range of services we're able to offer at the moment. So we're still working through that as every other trustees in the country in terms of how do we get back to the similar sort of levels as we managed to perform before. The charts here are our first attempt at providing some information. I think they're They're helpful. They show the impact of COVID over the last 12, 14 weeks, and also show our response to some extent. So fall in emergency demand very dramatically, which then steadily began to rise from late April, but still short, as Jane pointed out, of normal levels of activity. Although there are days of the week now when we are hitting some really quite high levels of activity, but it tends not to be sustained across the whole week. Ambulance conveyances have returned. It's not there, but it's later in my report. You can see a start of a spike which has carried on. Conveyances have now returned to almost normal levels most days of the week. Particularly Friday to Monday, we're seeing some quite high numbers of ambulance conveyances. Tuesdays have been, for the last 3 weeks, really, I said the Q word, calm in comparison to the preceding days. So there's some pressure there for an ED that's obviously running a 2 ED solution to manage COVID risk at the moment. Drop in activity and the impact on the shape of the waiting list profile, I think, becomes evident in the later tables there. We've had a significant reduction, continue to have a significant reduction in routine referrals, which has reduced the number of short waits dramatically. And obviously our treatments have also been reduced dramatically as we stopped doing all routine surgery and some of our urgent surgery in the first few weeks. So we've got many more patients waiting a long time than we have. So performance is falling very, very rapidly, and it's falling as we speak. And 52 weeks, although it doesn't show very high here, is climbing, and will hit many hundreds of patients before we manage to turn this around, just so the board's aware that risk is, I should imagine it's across the whole country, but certainly within Herefordshire, that's something that we can't avoid at the moment. And on a more positive note, cancer care has been more robust through the crisis. We used the Nuffield very early, our local private hospital, to support cancer care, and we also managed to perform reasonably well throughout all of that, and continue to provide an almost full range of services without just some local clinical adjustments that were nationally driven. So referrals were very low, which helped that to some extent, but actually they're now returning to normal, which I think is we're all somewhat relieved about. Although it's worth noting that there is some sort of concern locally, regionally and nationally about some of the surveillance and screening programs that aren't fully restored at this point. So there are some worries about what we may need to deal with later on. Excuse me. Another positive really is we very rapidly adopted a virtual clinic approach, initially by telephone and subsequently by video and telephone. And for the last 6 or 8 weeks, we've achieved nearly 50% of all our outpatient activity has been done virtually, supported by some remote phlebotomy services. So patients really are getting care closer to home service that we're looking to expand upon. In terms of restoration, along with the national ask, we've restored all of our urgent services. Some of those aren't running at the pace we want them to at the moment, but they are increasing week on week on week. So we're reasonably comfortable urgent services are back. We are running some routine inpatient services through the local Nuffield Hospital as well. And we are currently working through a plan to return some routine work back onto the county site. And that's a 3-step approach, which I thought it was just worth talking about very briefly. Firstly, there's a regular touch points to divisions to make sure that we're delivering the plan that we wanted to, in terms of are we seeing the referrals we expected, are we delivering the activity we hope to, and what's the impact on our long waiters, and how are we monitoring harm for those patients, or risk for those patients. Actually, is a much better way of thinking about it. 2, we're taking an assessment of what capacity we have available and how do we prioritise that and get that working safely. So that's something we're going to sort of conclude next week. And 3 really is not a national priority, but certainly is my priority, is an understanding of when we can reach a balanced position. So I think our first major milestone is when our activity equals our referrals, which may be many weeks or maybe even months to come, but we can at least stabilise the waiting list, which we may stabilise in quite a poor position compared to normal working. But if we can stabilise it, then we can actually take a view with how do we then address some of those long waits and start to reduce that. So rather than when will we recover our position, when will we manage to stabilise our position, I think is my priority at the moment. So we're working with colleagues across the trust to understand that. And obviously that will also give us an understanding of what the gaps in our capacity are and how we might fill them, and also what levels of activity we need to do to achieve a more stable, more recovered position. So I think that's all. I suppose the only one thing that's not COVID related
Thank you very much, John. And just going back to the point on the increasing waiting lists, just to assure members of the public, what we are ensuring as a board is we get the balance right between patient and their family's safety, our staff safety, as well as being able to address the backlog that we're facing. But we must make members of the public aware the NHS is open, it's there to serve you, and if you're unwell, you must use the NHS. Questions and perspectives to John. Richard, please come off mute if there are.
Yeah, just one question, please, Chair. John, you talk about delayed transfers and that the national requirement to submit a return has been suspended. You also say that it's really important that we lock in the progress that we've made. That's absolutely right. So, but I assume we're still keeping the data ourselves, so we know how well we're doing.
We're actually monitoring medically fit for discharge at the moment, which is running very low indeed. I think on average when we report it's 9 or 10 patients a day that are actually fit to go that haven't yet gone. The longest waiting is usually within 7 days. So, I mean, I think medically fit for discharge is much more sensitive than delayed transfer of care, which is a status rather than a health position. So we're using that at the moment, and we monitor that as a system every day of the week.
Thank you, Richard. Thank you, John. Grace, anything from you? Please come off mute if there is. Andrew, anything from you? Please come off mute if there is.
Yeah, it's really helpful presentation on waiting lists and waiting times. And I suppose my question is, to what degree is the community, is there community ownership for this? Because it's significant, isn't it? And the way it's moving. And the comments you're making, John, help in terms of seeking stabilisation rather than turnaround for a while. To what extent is the whole health community involved in issues of prioritisation, issues of potential harm? Yeah, that would be my question.
Yeah, and I think David and Jane would probably also want to comment, but there's been some fantastic work with primary care colleagues throughout the COVID crisis. Particularly on how we manage patients that are waiting, and there also is GPs are really keen to be involved in how we manage patients on the long waiting list and how we manage referrals differently. So we've had a number of conversations with them, and those conversations carry on a sort of weekly basis. So I think there is a real sea change in our approach, so less of a transactional nature in terms of primary care handed over to secondary care and vice versa, and rather more of a shared care approach, thinking how do we safely manage and prioritise these patients.
Which is obviously helped by the financial regime at the moment, John. David, anything you'd like to add?
No, I agree with John. We've got good relations. I think we are holding these waiting lists ourselves, and we just need to arrange a sort of a continual review process between ourselves and primary care as to whether any of these patients who were formerly routine become urgent and what have you. I think that's a new process we're moving towards developing.
Yeah, and I would say that we are aware that some members of the public, when they realise the need for self-isolation before coming in for a piece of elective surgery, choosing to come off of the waiting list, we would really encourage people with a need for elective activity to help us to help you by staying on the waiting list and allow us to look after you as you need to be looked after. Frank, any questions or perspectives from you?
Yes, just the one about the public knowledge. I sense that there's a really significant message in here, and I'm not finding it's making its way out into the community. And I wonder, are we engaging enough with the media? Because I think they'd be really interested in some of the commentary we're just hearing now.
Okay, thank you, Frank. Let's take that forward, John, if we can. And then, Christabel, any questions or perspectives from you? Thank you. And Nicola, any questions or perspectives from you? Okay, thank you. And any questions or perspectives from Executive colleagues, I'll just make sure I can see you, Howard, as I know you like to jump in. Okie dokie, super. So we're then on to workforce. So Jane, again, thank you very much for joining us.
Okay, I'd like to take the report as read. The main points I'd like to mention is the KPIs overall have remained positive in month, with the exception of appraisals, but that's a reflection of May and the pressure that people were under at the time. And then moving down, the other area I'd like to mention is sickness. The improvement has been recorded, almost a percentage increase, so we decreased the sickness level. This is reflected in the reduction in the number of COVID cases of staff being ill with COVID, which is more or less half the percentage, and that's also reflected in the cold, cough and flu figure, because that is where all the COVID patients, all the COVID staff were recorded. And the other area is really in relation to the, which Jane mentioned, to the Bane risk assessments. And we have been working with managers to support them to do this. And we are hoping over the next 2 weeks to work with managers to make sure they are all completed. There have been 1 or 2 people who have been invited but did not want to have the risk assessment, but we are working with them to try and persuade them it's in their interests.
Thank you very much, Jane. So questions and perspectives to Jane. Richard, anything from you? Andrew, anything from you?
Yeah, I was just wondering whether the sort of pattern of employment is changing. I'm a chair of governors of a school, and we had 91 applicants for a normal teacher post recently, and whether some of the trends here are actually a reflection that employment patterns are changing or going to change, have changed.
I think certainly across the foundation group, we're seeing a very similar trend across all of the NHS trusts that Glenn and I look after. And I do think that, you know, and Jeff might like to come back to this in a couple of months, that the recession, which we're obviously in, is going to make employment by the NHS a more attractive proposition for lots of people. So fingers crossed we'll have more nurses, more people wanting to enter the profession in different guises going forwards.
When you look at medical, when you look at medical staff agency levels, picking up Howard's point, that seems that's pretty stubborn, isn't it, in terms of coming down? And I don't know whether the same thing is happening amongst medical staff.
Yeah, I think it would be good to come back to that, Howard, once you've been able to work out the lags, as we said earlier. But let's make sure we do that for nursing and medical staff. Frank, any questions or perspectives from you? Grace, please come off mute if there's any questions from you. And Chris, any questions or perspectives from you? And finally, Nicola, any questions or perspectives from you? Any questions or perspectives from exec colleagues? Please come off mute if there are.
Russell, just a very brief, really, just to respond anecdotally, really, to Andrew's question. So certainly my senior nursing colleagues feel that turnover within their areas has reduced significantly during COVID. And the other thing is just, it was only a small team, but you will recall we recruited a small team of admin staff to support the drive-through swabbing hub. And a number of those admin and clerical staff have said how much they want to move into healthcare support worker type roles, which is great to hear as well.
Super, thank you. Just 2 quick reflections from me, and it sort of partly builds on what you were saying there, Lucy. I'd like to put on record my enormous thanks for all of the frontline staff who have done incredible work, as we heard again this morning, but also those who work behind the scenes in hotel services, our strategic partners at Sodexo, those who do the cleaning, those who do the admin. We're incredibly grateful as a board for the part you play in delivering the health care that we do to the people of Herefordshire. So on behalf of the board, a big thank you. And on the subject of thank yous, James, you've done a great job over the last few months in terms of the handover. And on behalf of the board, thank you very much. And as we said earlier, Jeff, we look forward to hearing your voice next month. Moving on then to the money. We live in strange times, Howard. How's the money?
We do indeed. So just a couple of highlights I was going to bring out today, because again, in month 2, we've reported break even again. This month, we didn't require the additional top up. You may recall that last month, in month 1, we'd needed an extra 496k. The reason why we didn't need additional money this time was primarily because expenditure on the underlying activity was lower than normal for the reasons already discussed, but also we spent materially less than on the whole COVID, the COVID sort of infrastructure, for want of a better word, than we had in the previous month. Consequently, our spend was lower. So having said that, though, we are conscious of a few cost pressures beginning to bubble up, and most notably in relation to pay expenditure in A&E. And this is being investigated, and I'm expecting an update on this at the forthcoming finance and performance meetings, because this is a concern. Other pay pressures have been identified in integrated care and clinical support, and we are asking colleagues to make sure that they keep a close eye on these and keep a tight grip. In terms of capital, we're working to a capital programme which will be referred to in the next item by Alan. But in relation to the funding from bodies like NHS Digital, we're currently in discussion with them, because of obviously the whole process for getting money towards our IT schemes has been affected by COVID, and we're currently within negotiations on that. My final point is that cash flow actually remains comfortable. The figures look quite surprising in the paper, I'm sure, but this is thanks to the additional cash that has been put into the system. And colleagues will know that we're not having to take out loans anymore as the system's changed as part of the new infrastructure. So compared to many of the finance reports I've had to give in the past, this one quite straightforward, I think. But happy to take any questions.
Have we ever had such a good cash balance, Howard, in your tenure?
Absolutely not, no.
Richard, any questions or perspectives from you on? Thank you. Andrew, anything from you? Frank, anything from you? Grace, anything from you? Please come off mute. Chris, anything from you? And Nicola, anything from you? And anything from exec colleagues? Members of the public, it's rare to see Howard with such a smile on his face when talking about cash. We therefore move on to the capital plan for 2021, which we'll take as read, Alan, but anything you particularly want to pull out?
Yeah, thanks, Chair. Obviously the capital programme's been impacted by the coronavirus outbreak. We have delayed some schemes that we might like to have taken forward this year. We have changed some of our priorities, and actually it's created some opportunities for us as well, which I wanted to pull out. And obviously some of the capital that we rely on from the centre has been delayed as well, and that capital that is being allocated via STPs has been very much to focus on deliverability in year, which again affects your priorities. So some schemes we've moved and are likely to be delivered in the future, and some schemes we've brought forward. And just to give an example of that to draw out of the paper is around theatres. So we've been carrying a risk for some time about the theatre roof on theatres 5, 6 and 7, which is jointly owned by ourselves and our PFI partners, and we need to take forward the repair of that. And we were looking to bring in additional theatre capacity sooner rather than later before we fix the roof. But the present situation has allowed us to created the opportunity, give us a window of opportunity to go in there and actually fix the roof now, whilst we're putting less activity through theatres. So that's an example of a sort of opportunistic situation that we've taken advantage of and got on and dealt with that risk. And in the meantime, develop our business case for theatres. Couple of schemes I'll pull out just as an update. Critical care expansion, 2 additional beds being delivered as part of a scheme that we agreed here some time ago, and those beds will be available in September. And the main scheme within the capital programme next year is obviously around the ward replacement, the hutted ward replacement, and 3 new wards. That scheme remains on track. There's very little delay through the outbreak, and that remains on track to open in January. One of the schemes we've brought forward is the skin centre work at Jail Street. We'd already agreed that business case, and therefore that was in a more advanced state of readiness, and so we've brought that forward. There are a number of IM&T schemes which many of you will be aware of, and the paper starts to give a forward look, but it kind of preempts the work that we're doing around the estate strategy, and the estate strategy looking over the next 5 years at the kind of estate that the Trust wants to develop will be coming to the board in the next month or two. So once that's ready, so we'll focus on that in a future meeting, I think. And I'll leave it there, Chair.
Thank you very much, Alan. Glenn, anything you want to add or perspectives?
No, I mean obviously the moving of the ward programme is probably the most important thing. I mean, there are some risks because of the supply chain of certain components of that project, but it's become all the more important for us to ensure that capacity is available at some point during this winter. So we'll keep the board appraised of progress on that. Okay, super. Thank you, Glenn. So inviting questions or perspectives. Richard, anything from you?
Just a quick point, Chair. I mean, this capital programme is based on resource available, but I mean, thinking in terms of the overall backlog of capital work, Alan, I mean, how do we stand on that? How does that look?
Well, there's a few things on there that it deals with many of the issues that we're trying to take forward at the moment. I think what I would say is there are some capacity issues that we need to deal with, like theatres, and I think additional theatre capacity is something that we identified in the capacity plan last year that we would like to have taken forward this year. It's not practical to do that at the moment. It may become practical and more important later on in the year, and certainly we're developing our business case around that, so that if further finances become available towards the end of the year, that we can take that forward. The programme deals with most of the risks that we face within our backlog of maintenance within the Trust. And the biggest element of backlog maintenance in the organisation is dealt with by the replacement of the hutted wards, because that's where all our risk lies around that. So this picks up most of the risks around that.
Thank you, Alan. Thank you, Richard. Andrew, anything from you? Frank, anything from you? Grace, please come off mute if there's anything from you. And Chris, anything from you?
Thank you, Chair. I just wanted to support the development of the Skin Centre and also the expansion of the Urology One-Stop Clinic. I think anything we can do to improve patient experience going forward when people are going to be reluctant to be coming out on multiple occasions has only got to be good. So I just commend the management team for really moving forward on that. Thank you.
Thank you, Chris. And Nicola, anything from you?
Only that it would be really good to see, for example, the work that's going on with the hutted ward replacement. Hopefully we might be together soon and not on Zoom, and it will be lovely to see some of these things actually being built.
No, I think that's a great point, Nicola. Let's try and get something on the YouTube for members of the public as well, so they can see the way things are developing. Alan?
Yes, there'll be something really visible happening on site in the middle of next month when the big steel modules that have been fabricated off site start to be craned into place, and that might be a perfect opportunity to do that.
Okie dokie, great, thank you. Lucy's kindly offering to send some pictures to members of the board, which is wonderful. Moving on then to the digital programme update report. Sorry, before we go there, were there any questions or perspectives from execs to Alan on the capital plan? Jane?
I might be
Ladies first, Jane.
I might be able to say the same thing as you, Glenn. There's also sort of a quasi sort of bidding process going on at the moment in terms of the recovery programme. So, yeah, with our reduced productivity, what would we need? So we have bid for some millions of pounds within that. We don't really know what the process is yet. So we might suddenly get access to quite a lot more capital to put in endoscopy and day case units and theatres. So we'll see how that develops.
Okay, and I guess that goes back to Richard's point. And finally, Glenn?
Yeah, I was going to say what Jane just said. Probably just in addition to because of the issues associated with this, it's likely to be modular capacity that could be offered as part of the reset. So we're kind of thinking about how we could accommodate that on site.
Super, thank you very much, Glenn. So moving on then to the digital programme update report. Howard.
Okay, thank you. I'll take the report as read, but I wanted to pull out a couple of issues because colleagues will probably recall that this is the first report for a couple of months, and we've extended the report to cover all of our digital programme. It began initially as an EPR, then an EPR and EPMA, and now we thought we'd put a little bit of detail in about all the IT projects. We are still currently reviewing the impact and any delays caused by the pandemic, but it is fair to say that in a number of areas, as alluded to in the report, we have been able to continue a lot of the developmental work despite the pandemic, despite a lot of people working from home. In terms of EPR, much development work has continued, and you can see a list on page 75 of 127, the sort of things which have been continuing to be moved forward. A key date reached next week when we implement release 15.1, which actually introduces a lot of the required changes that people have been looking for over recent months, indeed years. EPMA, we've moved into testing, actively testing, which is positive. That keeps us, broadly speaking, on the timetable for that. And we have actually made a decision after many months for the replacement for the electronic discharge system. So those are just a few of the highlights. Happy to take any questions.
Thank you very much, Howard. I mean, just before I invite questions, I think this is an example of real great leadership from you, Howard. This whole area has been a real success for us over the last couple of years in terms of the progress we've made. Richard, any questions or perspectives from you? Thank you. Andrew, anything from you? Frank, anything from you? Anything from you, Grace?
Yes.
Anything from, sorry, Grace.
Sorry, I was not quick enough off the mark with the...
Grace, I can't hear you. I'm not sure if others can. Grace, I'll come back to you later if that's okay, and hopefully we'll be able to hear you. Chris, anything from you? And Nicola, anything from you? Okay, just going back. Grace, can you, I can't hear you at the moment. Could you try again? Okay, so Grace, we'll maybe try and pick it up under any other business, but I think we may have lost your sound at the moment. So we'll therefore move on to the Infection Control Board Assurance Framework. If there's nothing from the execs on the digital programme update.
Russell.
Lucy?
Just very briefly, just to say that we're really pleased that the EOBS, the electronic observations rollout's back on track. It's rolled out to 2 wards, 2 of our surgical wards this week. I plan the week after next to roll out to 2 further medical wards. And of course, what this really does is improve patient safety, which is really helpful. And the plan is that by September, we'll have rolled out to all of our clinical ward areas that that's intended for, which is really good news.
Thank you, Lucy. Keep us briefed on how that all works on the front line, if you would, please. And anything else from exec colleagues on the digital programme update? So then moving on to the Infection Control Board Assurance Framework. Lucy?
Yeah, so if I may, I'll just talk us through the framework. So the Board Assurance Framework was published at the beginning of May, issued by NHSI and NHS Improvement. and initially published as an optional self-assessment framework of best practice. Subsequent to that, it has been mooted that the CQC will monitor compliance against the board assurance framework. The framework's based on the 10 standards contained in the hygiene code. And it's probably at this point, I just want to make an apology. It's not easy to bring something as complex as this to board in summary format, because actually it's quite an extensive set of standards, an extensive set of guidance of which you have to make a self-assessment against. And as I say, that's not easy to bring that in a succinct way to board. So I apologise for the Excel spreadsheet, but that seemed like the simplest way to do that. As it suggests on the tin, it's a self-assessment. So in order for us to undertake this self-assessment, we pulled together a group of individuals, including our lead microbiologist, consultant microbiologist, myself as Director of Infection Prevention and Control, our lead infection prevention nurse, a compliance officer, a quality and safety officer, and our divisional nurses in order to make that self-assessment. The board assurance framework has been through Infection Prevention Committee and it went to Quality Committee last week. There are 61 elements within the framework, and we've assessed ourselves as fully compliant in 42 domains, partially compliant in 18, and we've got one area of non-compliance. I think the main thing to say about all of those is that they represent little or no risk, even though we're only partially or non-compliant. And if I could just explain that in a little bit more detail. For 14 out of the 18 actions that we're partially compliant with, in order to achieve full compliance, the practice has already changed. So we're already doing the right thing. We've already devised the SOPs or the policies or the procedures related to that change in practice. We just need to formally rubber stamp and approve them. So 14 of those 18 will be achieved by just the final signing off and rubber stamping of policies and frameworks. And they're coming back through to Infection Prevention Committee later on this month. And then the 4 that aren't related to policies or documentation relate to either pieces of estates work, so hand dryers and erection of plastic screens in reception areas. And there's a programme of work around those. One relates to an audit that had been suspended during COVID, but plan to restart that this month. And then the final one is just to make sure that we have a belt and braces approach to the segregation of our staff wherever possible when dealing with blue and green pathways. And it was always acknowledged that for smaller organisations, that was always going to be more difficult because it's more difficult with small teams to segregate your staff completely. So what's really important and where we're at is we've got a risk balance approach to that. What you really need with that is good infection prevention control practice and early intelligence to tell you where you might have a problem and testing. And we have all of those things in place here at Wye Valley. The one area of non-compliance is when we suspended our antimicrobial stewardship auditing, that meant we weren't reporting externally on antimicrobial stewardship, and that's the one area of non-compliance, but we plan to externally report on that from this month. As I've said already, any associated policies, action cards or standard operating procedures are coming through to Infection Prevention Committee later this month. Clearly, in order to demonstrate ongoing compliance with the framework, we will need to establish a monitoring process and also an audit programme for some elements. And that piece of work is currently being undertaken, and that will be presented also to Quality Committee in July, to Infection Prevention Committee in July. Clearly, there's an extensive amount. What you have in your board pack is a list of the evidence that would be available should the CQC come to inspect. And clearly that evidence is located in a central location and would be available to anybody who wanted to interrogate that for further assurance. Other than that, I'm happy to take any questions.
Very comprehensive, Lucy, and thank you for your leadership on this. And again, thank you to the quality assurance of the oversight. Richard, any questions or perspectives from you? Andrew, anything from you? Frank, anything from you?
If I may just support the comment that Lucy kindly made about the scale of the spreadsheets. If you look at the problem, that you've got little information in some cells and a lot in another, and it just spreads the spreadsheet, makes it unreasonable, unreadable. And we can change that by just using a different concept, because especially if we're looking at it on the screen.
Yeah, leave that with you, Lucy. And Grace, anything from you? Welcome back. We lost you. Okay, thank you. And Chris, anything from you? And Nicola, anything from you? Anything from executive colleagues?
Russell, could I come in? Yeah, I mean, I think it's really important that we have this as a separate assurance item at board today. There isn't a huge amount of national guidance coming down on this, nor does there need to be, actually. It is about our local governance around infection prevention and control. So I think it's important for Quality Committee to keep an eye on this, but I thought board awareness of the complexity and the extent of the response is important. I think one of the other areas of good practice is about access from the infection prevention team to the board or to subcommittee. So it may well have already happened, but that's something I'd encourage Christabel, if we've got that covered, that would be great.
Chris?
Yeah, just to assure the board and you, Glenn, that we did receive a presentation on this last week at Quality Committee, and we continually receive assurance from the infection prevention and control team on the work going forward, and we will support them, of course.
Great, thank you.
And any other questions from exec colleagues? Okay, keep us briefed, please, Lucy. So moving on then to committee summary reports. First is the Quality Committee of the 28th of May. Chris, anything you want to add?
Sorry, Chair. Thank you. Just to take the report as read, just to note, which is in common with other trusts, that our crude mortality rate has, of course, increased as a result of reduced admission. We have seen a sought assurance that there is no other reason apart from reduced admission rate that makes that ratio higher. So we've received that. Thank you. And again, that we've received an assuring report on how we care for the deteriorating patient. Again, we'd had last year a few issues with in particular cases, and there's been a huge amount of education and training of staff, and thank you to all who've done that. But there is great evidence now that we've really improved in that area. Those are the two things I wanted to raise, Chair. Thank you.
Thank you, Chris. Any questions or perspectives to Chris?
Just if I could add one thing, Russell, just because we touched on it at board a couple of meetings ago, was, if you remember, we received an update at board 2 meetings ago on the CQC action plan.
Yes.
And I committed to do a piece of work to say, did any of the must and do actions, did the context or relevance of them change given the COVID pandemic? So I presented a paper that Chris alludes to in her summary report to the Quality Committee. And what that actually highlighted is that of the just over 90 actions, the must and should do's that the CQC inspection recommended, over a third of them are compliance matters and will be dealt with through our usual compliance monitoring. There were only 11 really where the context changed. So we asked divisions just to consider them, and actually the remaining actions remain relevant despite COVID. I just think it was worth briefing board on that.
Thank you, Lucy. Colleagues, happy to move on? We'll therefore move on to the Audit Committee, the 18th of June, where we basically signed off the annual accounts. Andrew, anything you'd like to add?
Yeah, I mean, the accounts were approved by the Audit Committee. That was delegated to them by the board. I suppose the only thing is the qualification that is on the accounts, which really is in my view, is a qualification on the audit. That the audit was limited, and they therefore decided to raise it as a qualified opinion. I suppose my concern really is there doesn't seem to be consistency in the way this was applied across the UK. And also, I think that there was no reason in my mind for them to do this. I think the systems and processes in Wye Valley have been proven to be sufficiently robust to allow them to give us a clean opinion, particularly given the circumstances that we're all under, including them.
Okay, duly noted and minuted. Thank you, Andrew. Glenn, is there anything you'd like to add on that point?
No, I was just going to agree with Andrew that there hasn't been consistency across the group on this. Obviously, we have different auditors across the group. Next year, we'll have a different auditor at Wye Valley.
Okie dokie. So any questions or perspectives to Andrew on that report? Colleagues, happy to move on. And therefore we move on to the charity trustee meeting of the 18th of June. Frank?
Nothing to add to the report really, apart from an apology for the lateness of its arrival. It sits on page 96 of 124.
Any questions from colleagues? We then look at the REMCOM of the 18th of June. This is a verbal update from me where we discuss the appraisals of each of the executive directors, and each of the non-executive directors were in attendance. I don't intend to go into any of the detail of that. Any questions or perspectives on the REMCOM of the 18th of June? Okay, thank you. Then we're on to the Quality Committee minutes of the 30th of April. Chris, anything you'd like to add?
No, thank you, Chair. We discussed the summary of that at last month's board.
Any questions from colleagues? Thank you. So moving on to the Audit Committee, the 19th of March. Andrew, anything you'd like to add?
No, thank you, Chairman.
Any questions to Andrew on the minutes of the 19th of March? And therefore we move on to the Audit Committee, the 1st of May. Anything you'd like to add, Andrew?
No, other than this was a special audit committee set up just to look at the arrangements, financial arrangements around COVID.
Thank you. And any questions from colleagues? And then we move into the dim distant past, Frank, of the Charity Trustee meeting of the 12th of December 2019. Anything you'd like to add, Frank?
No, nothing to add, thank you.
And any questions from colleagues? So I'll move on to any other business then. Any other business, Erica? Just come off mute if there is. Chris? Jane? I would like you to stay for the private call, please, Jane. Glenn? Nicola? Alan? Jane? Jeff? Lucy? Frank? Andrew? John? Howard? Richard? David? Grace? Okay, well that concludes all of the business. I don't believe, Erica, we've had any questions from members of the public.
No, Chair.
Although I do believe we've had some people watching us live on YouTube. So if you are watching us live on YouTube, thank you very much. Hopefully it isn't all family members of the board. And if there are any questions, if you can please send them in and we will answer them. The next meeting is on the 6th of August. So thank you very much. Erica, apologies, just before we leave the meeting and the live stream, can you just remind members of the public the date of the AGM?
It's next Wednesday, Chair, at 5 p.m. The details are on our website, including the link to YouTube, so you can access it that way. But the 8th of July at 5 p.m.
Okay, please, members of the public, it would be great to have you join us for that live stream. In the meantime, take care, remember social distancing rules, and we look forward to hopefully seeing you physically again as soon as possible. Take care. Thank you. If you can